Hi, Dr. Brian Kaufman, Chief Medical Officer, Executive Vice President of the nonprofit CLL Society. Dr. Stilgenbauer.
Hello, my name is Stefan Stilgenbauer. I'm a professor of medicine and medical director of the Comprehensive Cancer Center at Ulm University in Ulm, Germany. Thank you very much for having me.
You've been involved with a global research group in CLL that has had a novel approach of looking at two primary endpoints, MRD, or minimal or measurable residual disease, and PFS, or progression-free survival, which is essentially the patient has to live and their disease does not progress. And seeing if we could use the MRD, which shows up earlier if it becomes detectable, versus progression-free survival, where often you have to wait years until there's enough patients who've progressed, what the researchers call an event when they progress. Could you talk to us a little bit about the link between these two, what's proven, what's not proven, what do we know at this point? Is MRD a good surrogate marker for progression-free survival? Because patients, what really patients care about is overall survival and progression-free survival.
Absolutely. I mean, what we all care about, as you say, is overall survival or possibly even cure of a disease, isn't it? We have this long-standing surrogate of progression-free survival that is somehow linked to overall survival and something that we can measure earlier, because disease progression occurs earlier, fortunately so, frequently than death due to the disease. Now, the thing that we can measure even earlier than that is minimal or measurable residual disease, which can be determined immediately after or shortly after treatment, and the depth of the response and how deeply and thoroughly we got rid of most, if not all, of the CLL cells in the body is the principle of this. Now, in the era of chemoimmunotherapy, we have lots of data that tell us that the depth of response, i.e. how little the measurable residual disease is related to long-term outcome. We have also in the venetoclax-based treatments, so the treatments that lead to this deep response like chemoimmunotherapy did, very good evidence by now that MRD is related to outcome with regard to progression-free and overall survival. The caveat is that we have treatments such as the BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, to name a few, where the response is more shallow. Albeit there's long-term disease control with these treatments, we don't have that brisk onset and very deep response. So with these types of treatment, at least with regard as a monotherapy, MRD is not such a good measure of long-term outcome. But in the trial that we had discussed, the CLL13 or Gaia trial, all treatments were either chemoimmunotherapy in the control arm or venetoclax-based in the 3 experimental arms. So in that trial, we expect MRD to be a very good surrogate marker for longer-term outcome. And we have to wait to have proof for this, obviously, but the initial data indicate that this is the case.
So another just quick technical point. After MRD, and we're using the words undetectable and detectable rather than positive and negative, we often see a number 4, 5, 6. Can you explain what those numbers mean in a kind of a patient-friendly way, and how accurate those numbers are and how they're figured out?
Yeah, so usually in the blood of a CLL patient, we know we have these, thousands, 100,000, millions of cells. You see them on the blood smear. But with the efficacious treatments that we have at hand today, we can get rid microscopically, at least, of all of these cells or almost all of these cells. So we need these new technologies that are either flow cytometry based or molecular biology, so PCR based mostly, to detect residual cells that may float around in the blood or in the bone marrow of patients. The methodology is so sensitive that we can detect one single CLL cell among 10,000, 100,000, or even a million CLL cells. And these numbers 4, 5, and 6 that you frequently see is the log on a log 10 scale, if you wish. So if you detect one CLL cell in 10 to the power of 4 normal cells, or to the power of 5, or to the power of 6. This is this 4, 5, 6 that you usually see. The accepted threshold for a long time has been 1 CLL cell in 10 to the power of 4. But we have new technologies at hand that really push that threshold deeper. And this is obviously huge technological advance, because we believe that en route to cure of CLL, we have to get rid of all of those cells and have MRD at the lowest potential level.
This is very exciting. I've always said that while MRD is not a cure, you don't get to cure without passing MRD on the way. So I'm very excited about this, and excited that we have better technologies to go even deeper and look further. Any thoughts about how you see this influencing research down the line, or final thoughts for patients to understand the importance of MRD testing and how that might be a marker in future trials?
Yeah, so MRD measurement is obviously very informative and very helpful, as you say, in clinical research, in clinical trials. It helps us determine earlier and more sensitively what outcome in the longer run may likely be. And the better the treatments get, obviously, the more sensitively we have to measure the disease residues. Now, on the other hand, in general practice, we are not in a position yet to really direct and guide treatment decisions based on MRD. It may sound a bit disappointing, but we don't have the body of evidence to do that. In other words, changing management based on a positive or negative or measurable or not measurable MRD result is not justified outside a clinical trial setting. This is a caveat that we have to say in that whole, to state in this whole context.
I'm glad you point that out, because a lot of patients are pushing their doctors to understand their MRD status. Any final thoughts you want to share with patients on this sort of evolving topic?
Yes, right. I think, this concept of scientific disease measurement, scientific disease understanding is very, very important. We have great treatments at hand. We have to understand even better how best to use them. And we are, as doctors and trial staff, are in a great position today to have these tools at hand. But the most important thing are obviously you, are the patients, because you are the actors on the stage. You are the important guy is really driving the field forward, because if you don't enroll on trials, there won't be any progress. All patients today benefit greatly from the progress that has been made over the years and decades by others who have enrolled on trials. And now you are the heroes. Today you can help move the field forward, and we are terribly thankful, very, very grateful for your extra efforts in help moving this field forward. I thank you very much for all of this.
And we are very grateful for the research and patient care that you're offering. Dr. Stilgenbauer, thanks so much for all that you're doing.
Thank you.